The last in our series of Alzheimer's lectures. We're so glad to have another full room, and I would just like to kindly remind people to turn their cell phones off if you do have your cell phones with you. I will mention the exits are behind here and there in the event of emergency, but we're not going to worry about that. And with that said, I will bring up the man that is largely responsible for helping us organize these 3 lectures in October. He is a trustee and a former editor at the Providence Journal. Tim Murphy. Thanks, Tim.
Hello, everybody. Just out of curiosity, I'd like to show of hands of how many people have been to all 3 programs. A lot. I thought I recognized a lot of faces here tonight. So I know that I've learned a lot over the past few weeks from our speakers and also from the great questions and comments from people in the audience. And I hope you've learned a lot as well. At the end of tonight's talk, we do ask that you fill out a brief survey to give us your comments and suggestions for future programs. We have 2 guests tonight. First is Annie Murphy, Program Manager of the Rhode Island Chapter of the Alzheimer's Association. She's the association's primary contact for care consultations and education for caregivers and professionals working with people with memory loss. She also oversees the chapter's support groups and the early stage social group for people with early memory loss. And second is Michael Porter, a community educator for 8 years and a former caregiver. He gave care for his sister who had early onset Alzheimer's disease. So please join me in welcoming our speakers tonight. Thank you.
So, hello everybody. Again, thank you so much for coming out on this beautiful fall evening and taking the time to come and share and be present with us for the next about an hour and a half. Like Tim said, I'm actually been with the Alzheimer's Association for 10 years now. And in my position, I have had the opportunity to meet and talk with thousands of caregivers here in Rhode Island and people who have been diagnosed with Alzheimer's disease or other related diseases over these past 10 years. I'm also a former caregiver for both my parents who were living with dementia. I was a young caregiver in my late 20s. About over 19 years ago. And I wish that I knew and that I had educational programs like this and support that we're so lucky to have here in this community. So I think it would have made my role as a daughter and a caregiver for both my parents probably a little bit easier. I was amazed because both my parents were physicians. And I still cringe when I think about the fact that no one told me. And, I thought I was getting, my parents, we have the best real care, but I've learned so much in my position here at the association. And I have to tell you, I've learned most of what I've learned from you. I've learned from my caregivers. I've learned from the people who are living with the diagnosis of Alzheimer's disease or another related dementia. And I've learned from, direct care professionals, people who are, caring for people day in and day out in home care, assisted living, nursing facilities. So this evening, I just wanted to talk briefly to let you know a little bit about who we are and what we do. And then I'm really going to hand it over to Mike Porter, who's actually I can't tell you, he's an incredible friend. He is an incredible educator from someone who lived the disease, and he's able to just bring light to this topic. I think it's so crucial that we really understand why behavior occurs and what is dementia-related behavior, and how we as caregivers, supports, how we need to learn to understand why behavior is occurring, and what we can do to support the person with the diagnosis so that they can ultimately live their best life through the journey of Alzheimer's disease and dementia. Association is a national nonprofit volunteer organization, which has actually been around since 1983. We're out of Chicago, Illinois, and we are actually in every state in our country now, including Alaska, Puerto Rico, and Hawaii. Our chapter is actually located in Providence, but we provide support and care throughout the state of Rhode Island. We are about 2,000 people strong. And the types of services that we offer at the Alzheimer's Association, there's no cost for any of our services. We provide care consultations, which we assist family caregivers and people living with the disease. We help them plan for that person's care. We offer support groups in the state. We have 26 support groups throughout the state of Rhode Island. And that's just a lovely opportunity for those individuals who are living with the disease to make those connections with other individuals so they can learn from each other and get the support that they need from each other. We have a lot of support groups for caregivers, and I can definitely share with you where a lot of those support groups, if you want that information in the future. We have an incredible website. It's called alz.org, and it is, which I think is the most incredible website where you can provide to get a lot of education and a lot of information on what Alzheimer's disease is. There's an opportunity for you to create a care plan. So depending on where you are in the disease, the stages of the disease, that will help you kind of choose what you should be doing at this time and maybe in the future. There's opportunities of just all sorts of topic sheets to get that. We offer a 24/7 helpline where we have master level clinicians 7 days a week that you can call about anything. If you're concerned about your own memory and you're kind of wondering, what should I do next? How should I proceed? What is a neuro evaluation? What does that entail? I'm just at my wit's end providing my care right now. I need to talk to someone who truly understands what I'm going through. We can help you problem solve. If you're dealing with a particular situation in your household, you can kind of help try to figure out how you might be able to best deal with that situation. But we're available for you 24/7. I'm the helpline clinician here in Rhode Island. I take those calls during the day from 8 to 5. And I see many faces and many voices that I know from just past experiences. And I thank you guys for just allowing us to provide that service and support here in the community. We don't just provide care and support for our families and people living with this disease. We are very, very aggressive on both the federal and state policy. Just recently, we updated the state plan on Alzheimer's disease, and right now we're going around, and we actually just had our town hall meeting here in South Kingstown last week at the senior center, explaining what we have done here in Rhode Island on a local level with passing some legislation that's going to really improve the quality of care that people are going to get in the future. We are just very excited that we actually just passed a requirement that physicians and nurse practitioners and nurses are required to have dementia care training as part of their licensing requirements, something that we've never done before. We also are trying to pass legislation to increase respite funding. Unfortunately, I think it was about 6 or 7 years ago, our state government actually got rid of a lot of our respite funding that was available. And we were able to pass it this year that we're to increase the funding by, I think, $118,000 to provide additional respite funding for folks who are needing a break. So that maybe someone can come into your home and provide a little bit of time, supporting your loved one so that you might be able to get out of your break. We are extremely lucky that we have very supportive representatives here in South County in the Narragansett area. I encourage all of you, if you have the opportunity, you have some voice, something that you really want your local representatives to know about, telling your story. Tell your personal story. You know, send an email, call your representative. I'm sure they'll love to hear from you. But that's how we're going to be able to make change here in the state of Rhode Island, is by letting your legislators know what are your concerns here. We continue to, we have, I think, 9 or 10 more town hall meetings that are scheduled throughout the state of Rhode Island, because we want to hear from the community. We want to know what the gaps are in care. We want to understand what are the concerns, what is the state doing well? And we're taking that information and deciding, you know, what are going to be our future plans of action regarding state policy here in Rhode Island. So that's a little bit about who we are and what we do. Is there anything else? Oh, I know another big piece, research. The Alzheimer's Association is actually one of the largest funders of Alzheimer's research internationally. We have a very, very robust campaign and research loan and lending opportunities. We have researchers going after the Alzheimer's Association for loans to support research internationally. We have, we convene every year. It's called the AAIC, which is the Alzheimer's Association's International Conference, where this last year it convened in Las Vegas. And we had over 700 researchers internationally come and convene for 1 week to really understand the research that's going on and what are the trends. Because it's so important that we continue to understand, you know, what are the trends in research. I know we had 2 local researchers for the last 2 weeks, and I hope, I'm sure that they were a plethora of information and knowledge for all of you that were part of that. One thing too, I also want people to be aware of is we actually offer a service. It's called Trial Match, and as I call it the dating service of the clinical research. But you can learn about clinical research, clinical trials that you could be eligible for, whether you're someone who has had Alzheimer's in your family, whether you are a caregiver, whether you are just a healthy subject and wanting to, you know, benefit those in the future, or if you're someone who's living with MCI or Alzheimer's disease, you can use this service to complete a profile on yourself, and then it matches you to your specific information that you put in, and it gives you that information to find out, you know, maybe you are interested in clinical research. We're really lucky. Rhode Island is a hub for clinical research. We have over 30 clinical trials that are going on right here in Rhode Island. And I can tell you that I'm going to encourage all of you to stay tuned over this next month. There's this really exciting information that's going to be coming out that is really going to affect us here in Rhode Island and is going to affect us New England-wide, that we're all going to be able to benefit from. So I'm really excited about that. So I want to thank you all for being here. Does anybody have any questions for me before I turn everything over to Mike? Yes.
Would you repeat the website that has the information on there?
So it's www.alz.org. Yeah, it is. It's yeah. Sometimes it's almost overwhelming the amount of information, but I'm now sort of using it myself. Sometimes like, whoo. But again, thank you very much. I'm going to now turn it over to Michael Porter, who's going to be talking to all of you this evening about just understanding dementia-related behaviors. And so, Michael, take it away.
Good evening, everybody. Can you hear me in the back? Before I start, my wife is sitting halfway down there in the blue shirt. So I know she doesn't like the glitter and everything, but I have to introduce her because she's my right arm. Basically, when Andy calls me, I travel the entire state. And I've been lucky enough in the last year to have her come with me and help me out with the paperwork and stuff. So, We have been involved with the Alzheimer Association since 2005. We had a store, and we used to sell the little pins and stuff there for the Alzheimer Association. At that time, forgive me when I say I, because my I is equal to we, because if I don't say we, I'll hear about it later on. Believe me. Anyway, in 2005, we were selling this in the store, and at the time, we were taking care of my mother-in-law. My mother-in-law had dementia with Lewy bodies. She passed in 2007. So, in 2012, we felt there was something wrong with my sister. This is a picture of her up here now. She's 59 years old in that picture. 59 in 2012. I called her to Thanksgiving before Christmas and said, hey, you want to come to the house? We're going to decorate the house for Christmas. And she said yes. She met me at the door with her bags, packed up, never to go back. Within a couple of months, I was able to get her the diagnosis of early onset Alzheimer's. Early onset Alzheimer's is anybody who gets Alzheimer's before the age of 65. She lived with us for 4 years. Everybody would say, why did you do this? Her son would call and say, why don't you just put her in a nursing home? Okay? 59 years old, she was still driving a car, and they want to just put her in a nursing home. We figured, all right, we've already taken care of our mother-in-law. This should be a piece of cake. We got it down. We know what we're doing. Wrong. Totally wrong. No two Alzheimer dementia patients are alike. None of them. Everything is a routine. As deterioration goes, you're constantly changing and trying to come up with new ideas. So I drew my line in the sand, and within 4 years, we had to put her in a nursing home. She passed June of last year. So as time goes on, during taking care of her, my mother was diagnosed with vascular dementia. She had had operations on both knees, both shoulders, constant operations on her back, and then finally fell and broke her ankle, which required another operation. Bingo, vascular dementia. The anesthesia affected the brain through the blood veins and arteries in the brain. So now she's got vascular dementia, bipolar, schizophrenic, and there's a whole line of other things, and we just put her in hospice care 2 weeks ago. So our story keeps going. So she is in a nursing home, like I said, in hospice care, and we're waiting to see how long that's going to go on. One thing I want to bring up for everybody who's a caregiver. If you're a caregiver, you have to be your loved one's advocate for everything. Making sure they get the care that they need. Right now, we're constantly monitoring what's going on with my mother and what she needs for drugs and stuff, because we're into the end stage. So you're an advocate all the way to the end. The reason I bring up my sister on the picture, they say a picture is worth 1,000 words. I have like 14 different presentations that I give across the state. And my way of doing this is, I take you on a personal journey of what we have gone through. The stone walls that we hit, the changes that we had to make, the routines that we had to change. So when I talk about Carol Ann, and this is what I did, this is what we did, that's who I'm talking about. All right, any questions so far? Yes?
Could you say again the connection between anesthesia and vascular dementia?
Do you ever have any operations at all? Do you go in, have anesthesia, get knocked out?
Right.
Okay. Nowadays, you have 2 anesthesiologists there all the time monitoring what's going on. So, you get too much anesthesia, all right? It can disrupt the blood flow in the brain. When you disrupt the blood flow in the brain, wherever the blood flow has been reduced, those brain cells in that area are going to start to die. Okay?
Thank you.
So it's interesting to note, and I'll just, that there's actually a very important clinical trial that's actually going to be starting right now here in Rhode Island, specifically on that connection between anesthesia use and the potential of cognitive decline. It's actually going to be out of the Marion Hospital. And the key investigator, her name is Lauren Diallo. So just to be familiar with that.
Yes?
I would imagine that anybody who has had an operation
Yeah.
and seemed to been affected by the operation and the anesthesia, this should be, I have a brother who died of that, not of that, but they said it wasn't the anesthesia, they dismissed it.
Mm-hmm.
Now, if there is, you're saying the experts know that you can get it through anesthesia, shouldn't we, be much more active in trying to realize, as far as putting the anesthesia in, how much, too much, what not, there should be, it's not needed to do that, it's the anesthesiologist and their association.
Okay.
I would imagine.
In her case, it's too much anesthesia. She's had too many operations. All right, and I'm saying one operation anesthesia done. I'm saying, in her case, both knees, both shoulders, multiple surgeries on the back. And from the last surgery that I had, now I'm seeing there's at least 2 anesthesiologists in there with you, and you'd love to get that extra bill when you're all done. Let me tell you, they get you. So it's just another form of possibly altering the circulatory system in the brain. All right? Guy riding a bike falls over and hits his head. Now he's got a traumatic brain injury. He has dementia. Have they gone through the difference between dementia and Alzheimer's?
Yes.
Okay? Dementia is the overall broad term. Under that, you'll have Alzheimer's, Parkinson's, Down syndrome, mad cow disease, and all these others. Yes?
What percentage roughly for Alzheimer's out of dementia?
80% of dementia cases are Alzheimer's. It is the leading dementia. Yes?
I have a question, not to go far astray, but what about chemo and its effect on Alzheimer's?
And it's,
Yeah, I mean, I think there's definitely, I know there's research being done, particularly in that area. And, you know, they're looking at, is there a correlation between that and cognitive issues? I mean, you've heard that term chemo brain, which, you know, for people,
The
they
patient already has Alzheimer's, and now the possibility of.
Yeah, I mean, I don't have the science, but I know that that's a particular area that they're looking at. What I will say to all of you is that, you know, if there are particular areas of research and that correlation between, you know, certain risk factors, you can learn more, you can find out more information, you can reach out to our librarian at the Alzheimer's Association if you wanted to you know, see more articles specifically on those particular areas, so.
Okay? Yes, in the back.
This might be too far astray, but MS, when you have multiple sclerosis, it causes changes, you know, in sort of things that can affect cognitive thinking and things
Yep.
like that.
Yep.
How does that relate to an older person that might have MS and like what's going on physically, biochemically with changes in the brain and stuff like that? I don't know if that's too broad.
Again, I think, you know, I'm not an expert in that particular area, and I never say that I'm an expert in anything with this, but, you know, I definitely think those are questions that I would go back to your physician to talk to him or her about. And I know, for example, there is a correlation between, you know, folks that have has Down syndrome. And if they live long enough because of the 21 chromosome disease, that they will, there's about a 98% of chance if they live long enough that they will develop dementia. So it is, you know, again, I'm sure we could, you know, get some information more that, you know, assist you, but.
I'm a retired nurse and I've always been interested in
Yeah,
that.
absolutely, I agree. Yeah, I think it's definitely a body of research that I'm sure that they're looking at.
Yes.
Are you the sole caregiver then for these people you mentioned, or do you have brothers and sisters? I know you had the one sister, but.
The one sister, my wife and I were caregivers. I did have a younger sister, but she lives 13 hours away.
Okay, so everything falls on you.
Everything,
Okay.
everything. For my mother right now, I share that with my younger sister. But they've been calling me and getting, because of my background and what I've been doing, they'll call me for everything. Yes. Yes.
Is there any typical duration from the onset of early Alzheimer's to a person's death?
On early Alzheimer's?
Yeah, it was like 4 years you mentioned to your sister. Was that typical, or is it, that was usually?
Once the signs and symptoms start showing, the person has already had Alzheimer's for at least 4 years. They just haven't shown the signs and symptoms. In her case, her daughter got married in 2006, and her daughter came back to tell us later on that she felt there was something wrong with her, but never said anything. You know? So, and we didn't get her in 2012. And that's when she was already past the beginning stage and already into the middle stage. So it varies. There's people out there who've had it for 20 years. They're probably laying in a bed in a vegetative state, and that's their life, but they'll have it for 20 years.
On average, the Alzheimer's Association is saying between 3 and 8 years from the onset of symptoms, outward symptoms. Between 3 and 8.
What was that number you said?
Between 3 and 8 years.
8 years?
But like Michael said, people are, you know, living much longer with the disease. You know, I had a wonderful neighbor who, I live here in South Kingstown, and she lived with the disease for 21 years. And she was an extremely healthy individual and did everything proactively that she could so that she could, you know, kind of combat, you know, the symptoms that she was experiencing.
All right? Basic understanding. Problem behaviors are generally a problem for the caregiver, not for the patient. Why do we say this? The patient doesn't know. The patient doesn't know they're being bad. They're not being socially correct. It's up to the caregiver to make the changes. It's a problem for the caregiver. We had back a few years ago, it snowed 3 weeks in a row. Every Monday it snowed. And at that time we had my sister in a daycare center. So when it snowed, they would cancel the daycare center. Now it's my problem. We've disrupted her routine. We've disrupted her meals. We've disrupted everything that she is used to. Wasn't a problem for her, it's a problem for us. Behavior is neither good nor bad. Again, they don't know. This is a disease that you're seeing. They can't change. You can. All behavior, even difficult behavior, needs to be understood in an attempt to communicate. When you get in your car, what do? Okay? You get in the car, you're in that situation. You gotta straighten your mirrors. You look and see what you have to do. You're in that box. You know you gotta fix your mirrors. You know you gotta make sure your lights work. You gotta turn the key. You gotta make sure nothing's outside. You have to be aware of everything that's going on. When I teach firefighters, I used to be an EMT instructor for years. One of the things we teach them, you come up on a scene, what do? Are you gonna go run for that fire? No. You're gonna assess the situation first. You're gonna see there's a fire. You're gonna look around and see what kind of fire. You're gonna look and see if there's any wires, tires, or fires that are going on that you can't get near. You are number one. Same thing when it comes to your loved one. If something is going on with them, they're aggressive, they're argumentative, they're combative, step back, put yourself in their shoes, and see why. If they're walking around the living room and they're hunched over, holding their stomach, and you see that, that means something. Maybe they gotta go to the bathroom. If they're in the kitchen and they're walking around in circles and they're in the kitchen and you don't know why, maybe they're thirsty. But you have to be the ones to observe, put yourself in their shoes, and try and find out what the problem is. Because if you have to go to the bathroom, and you're outside in the woods, and you gotta go, how do you feel? Not too good. Picture them, and they can't communicate. All behavior has purpose, and difficult behavior in persons with Alzheimer's disease is not willful, it's caused by the disease. They can't communicate that to you. You have to stand there, look at them, assess the situation, and see if you can come out with the reason. And then come out and find what to do about it. Change is caused by dementia. A person with dementia is experiencing mental state changes. The ability to think clearly, problem solve, and communicate is impaired. You've already been told this is a disease. It travels around and through the brain. As the disease travels to different areas of the brain, it's going to kill brain cells. If it kills the brain cells to take care of walking, are they going to have problems walking? You bet they are. They'll probably go from walking to using a walker to a wheelchair, and then to a bed, and you can't get them out of that bed. It's a progressive change. Not able to interpret the environment or what is going on around them. Family dinner. Have your family come over, your loved one is there, 3 or 4 family members, and everybody is talking. They don't understand what's going on. They can't follow the conversation. They might be able to listen to one person at a time. And in my sister's case, if it was my wife, myself, and her at the table, she might hear a couple of words, my wife would say, a couple of words. And then she might hear a couple of words from me. And then totally come out with some gibberish. They can't follow a conversation. She was a social butterfly. Guys in high school used to want to be my friends just so they could take her out. By the way, she went to prom too. So, she went from being a social butterfly, and her job was here in town, and she had all sorts of customers, and she'd be visiting them all the time. She was a social butterfly. She loved it. As time went on, she's not interested in talking to people. She couldn't use a computer. So instead of the company trying to find out what's the matter with this outgoing person, we fire her. Go on. So we went from that to maybe having her go out with her girlfriends 3 or 4 at a time. And then that progressed down to maybe a one-on-one. Till she finally reached the point where she was in her bedroom and not coming out. Why? Because she couldn't be social. She couldn't understand. She couldn't put this together. Feeling disorientated and out of control, and frustrated at not being able to do simple tasks. So when she first came to the house, she would ask for something to do. My wife would say, "Why don't you help me with the salad?" Take the lettuce, tear it apart, put it in a bowl. Take some tomatoes, put it in a bowl. Cucumbers, whatever else, put them in there. And that worked for a little while. Then she couldn't figure it out. Couldn't figure out how to break up the lettuce. Couldn't figure out how to put the tomatoes in the salad. She used to like to be able to set the table. Eventually couldn't do that. Couldn't do it at all. Couldn't figure out the place settings, 1 fork in each place, for 3 of us. Totally disoriented. Not getting it. Same thing with eating. You sit down to your family dinner, you got this nice big plate, and it's Thanksgiving, and you have turkey and mashed potatoes and peas and carrots and stuffing. It's too much. They can't comprehend that. They can't figure out what they want to eat first. They just sit there and look at it. And maybe in the beginning, in the early and part of the middle stage, they can use a knife and a fork and a spoon. Then eventually, they can't use a knife, so you get that out of there. As time goes on, they can't use a fork. They can't figure out how to pick it up and put it in there and eat. So you go with just a spoon. And you cut up the meat and stuff. But you give them one thing at a time. You might just give them the potatoes, and they'll eat that. When that's gone, give them the carrots, they'll eat that. because they can't comprehend all the things on this plate and what to do with it. So it's up to you to realize what's going on and what you're going to do about it. Causes of sudden behavior changes. Physical discomfort. Okay? They're hunched over. Medications. Anybody in here have high blood pressure? What happens when you have allergies or cold and you go to CVS and you buy a cold remedy that's a decongestant? All of a sudden your heart's going like crazy. Medications interact. Your doctor should be watching all the medications that you're taking and see what you can take and what you can't take. You should also be talking to your pharmacist. So you don't know, you make a doctor's appointment, you get that appointment for 6 months later, but your pharmacist is sitting right there. All you gotta do is ask him what you can take and what you can't take. Body chemistry changes. I can tell you as this disease progresses, they wither away right before your eyes. When we first got her, she was 248 pounds. When she finally passed, I think she was 79. You want to talk about deterioration? Unbelievable. And you see it every day. And you live it every day. But you still got to be their advocate and still take care of them.
So sometimes, I think when you're in the caregiver role, like Michael and Donna were, being such, one-on-one primary, that sometimes they, and I apologize for this, sometimes you'll need another opinion. You may, I would really encourage, that you have friends and maybe additional family members, if you can, to kind of say, this is what I'm seeing. Is there anything that you're thinking? Because sometimes when you're in that caregiver role so much, that you sometimes become blind to what is you're actually seeing. And you may not be seeing things that may be occurring because you're so in it day in, day out. And I think it's really important with these sudden behavior changes that you need to really pay attention if it's a real sudden behavior. Because it could be a medical condition that could be causing it. It could be urinary tract infection. It could be, the high blood pressure has increased. It could be a problem with your sugar. So you need to make sure that if it's a sudden behavior change that you seek and talk to your loved one's physician to make sure that something not medically going on. I can't say how important it is with medications. There are so many interactions with people with this disease and medications that they're on. They're not able to absorb the medication as easily as they used to. And so they are very easily susceptible for side effects from medication. So you really need to understand that their body is metabolating is much slower. And medications can become toxic when maybe they're taking something for years. So just be aware of that.
UTIs.
Yeah.
Urinary tract infections. If somebody gets one, and by the way, guys get them too.
Yep.
It's not just women. Guys get them too. But a UTI with somebody with Alzheimer's exacerbates the situation. Makes them a lot worse.
Dehydration, too, can really, really, really bring on some of these sudden behavior changes. So we really need to because again, they're not able to absorb, liquids as easily as they used to, and they may be, urinating a lot more frequently as well. So we really need to pay attention to whether dehydration is the issue as well.
Yes.
Now, why would they be urinating more if they weren't drinking so much?
Again, when you're talking about the presence of this disease, all their functions changing. So, you know, it could be a part of the disease that's causing them to, you know, urinate more frequently, or their bowels changing, they're moving much more frequently. So we really have to pay attention to, you know, and I don't have a problem talking about urinating and, you know, excrements, but you really need to pay attention to people's systems. Because that will be such an important part in your caregiving role, to understand, you know, because we all have our cycles. We all know when we go to the bathroom in the morning, and the times, you'll need to pay attention to that in your caregiving role, because it's going to help you be able to understand that, maybe my wife is, like she said, maybe it's usually the time that she needs to use the bathroom. She can't tell you, but you know that she's someone that usually goes to the bathroom after breakfast. You need to pay attention to that. You need to understand their routines.
In relation to the liquids, as the person's body starts shutting down, they stop eating. So they'll drink and force more fluids. For instance, right now they're giving my mother these protein shakes. Okay?
Is she willingly taking
She's not taking anything to eat right now.
but the drinks?
But the drinks. They're managing to get that in. So they're watching how much of that is coming out and keeping track how much is going in, because by doing that now they can watch the kidneys and see if they're starting to shut down. Okay? Heart conditions, respiratory conditions, and cancer. Anybody who's had a heart attack, anybody who has asthma, know how these can alter your behaviors. Method of gathering data. Where the behaviors occur. You want to eat, you go to the doctor's office. These are things you should be logging. The time it occurs. Is it after 5? Are we dealing with sundowning at nighttime? Are we dealing with sundowning in the morning? What did they do all day? Did they sleep? Are they tired? When you come home, when we used to come home at night, we used to have to watch out, keep the dogs quiet, keep the lights down, keep the music down, keep the talking down. So all these things would just make her situation worse. Keep a log of it. Who is around when it occurs? Who's there? If they've not liked somebody for years and years and years, they're going to remember that. If they have a nurse in a nursing home that they don't like because that nurse isn't doing what they want, they're going to remember that, and that person's going to pay. But I mean, that's another thing to put in your log. There's been many people, for my sister and my mother now, they're not allowed in that room.
And it's also important too to, you think about like who they relate to really pay attention to their childhood. Think about, I use my mother as an example. My mother refused to allow anybody in the household who had dark skin. And after she passed away, I actually had a conversation with my aunt, and I found out that my mom was, her family were cotton pickers. And so they would travel from farm to farm based on the crop and would pick cotton. Well, found out that my mother might have been somehow maybe hurt by one of the cotton pickers, one of the migrant workers who had dark skin. I didn't know that. But I think if I had known that, I might have chosen an alternative person to provide that care for my mom, because I was setting my mother up. She didn't like the person at all. She would not let someone come in. If I had known that about my mom, then I might have, made some choices that were different.
My mother doesn't want a male nurse. She don't want a male nurse changing her. Out. And let me tell you, She has no qualms about picking up her food tray and throwing it. We went there a couple of weeks ago, and that's all I heard about is how somebody went there, one of the nurses went in the morning, she didn't want to deal with it, she picked that thing and threw it right at her. Keep a log. Examine separately as a whole the log data. When we take my sister to the doctor, I either had it up here or on a paper, what I saw. Now granted, I've got a huge medical background. Being a firefighter in emergency, I can assess people real fast. So we go to the doctor. First of all, I never told her we were going to the doctor. We were going to Dunkin' Donuts. Okay, let's go. Yeah, let's go. And I take my wife. My wife would sit in the waiting room with her first while I went in and saw the doctor and went over everything that I saw. And then eventually the doctor would call her in and he would say, "How you doing today, Carol Ann?" And she would say, "I'm doing fine." But now we knew what to look for. So keep a log. When it's happening, where you are, who's there, get all this down.
You know, it is important, especially if you have someone that's in your care, a spouse, you know, and they're in the early stages of the disease. I mean, it's like anybody, you know, we all see things a little bit different. It's nice to invite, you know, if you're someone who's dealing with cognitive changes, to invite a friend, a family member, a spouse into your appointments with you. You know, we recognize that, you know, with the cognitive changes, you may not be able to identify and see everything that your friends and your supports are seeing. They can help be a little bit of a relay to your physician as well. So, you know, we encourage that you invite individuals to come into your doctor's appointments with you.
Triggers. Yes.
Can you address compassion fatigue? And are there resources in South County? I thought I'd read in the paper they have a monthly breakfast at South County Hospital.
Yeah.
Do you know anything about that?
I do. So, here in the state of Rhode Island, there's a young woman by the name of Lori Nance who actually started what's called memory cafes. And it's an opportunity at South County Commons and Brightview Commons for you as a caregiver to come and just meet other caregivers, get support, conversation. Also, we invite people who are living with the disease to attend those as well. It's sort of a communal social opportunity. There are memory cafes in Westerly at the Elms. I think there's one in Cranston. There's a couple over in the East Bay area. I actually have all of the memory cafes available on our website if you want to learn more about that. So,
You have to be within like South County Commons to attend that?
no, you don't. Anybody could attend. I can tell you, I actually have a couple of families who go to all of them all month. That's what they do. That's how they socialize. And they're really enjoying them because it's just, again, it's an opportunity to do some activities, have lunch, or, you know, have a snack with people who are going through the same thing that you're going through. So, yes.
I get the invitations on a regular basis.
Mhm.
I'm not a caregiver. I'm a potential patient. But I don't drive, so I have to get there. But would that be appropriate for me
Absolutely,
to?
absolutely. You know, I think that would be absolutely wonderful for you to attend. We also have social engagement programs throughout the state of Rhode Island. The program is called Live and Learn. It's just an opportunity for people who have been diagnosed with MCI, mild cognitive impairment, or are in the early stages of a type of dementia, that they can come for just a social gathering every week for 2 hours. Our closest one here is actually in North Kingstown at St. Francis de Sales Church on School Street. And I mean, if anybody's interested after this presentation, I'm more than happy to tell you more about it. Okay, thank you.
Just just gotta get there.
Yes.
Talk about triggers. Why is the behavior changed? Pain. If you're in pain, how do you feel? How does that change your attitude? Incontinence, hunger, thirst. If it's 95 in here and it's hot as heck, and you're getting dry and you're getting thirsty, then you're going to start getting sleepy. Okay? It affects you. It affects them. Fatigue. How do you feel when you get worked all day long, you've worked a 12-hour shift and you get home and all of a sudden you sit in your chair, out. Same thing with them. Boredom, overstimulation, fear. Fear. Quick scenario. Woman with dementia is living in a house by herself. Calls her son every night at the same time saying, there's somebody breaking into the house. I can see them. I can see them in the window. They're breaking in the house. Son says, it's okay. It'll go away. So it goes on for time. Calls her every night. Calls him every night. So he finally says, okay, I'm going to go see what's going on. So he goes to the house, gets there an hour or so early, talks to his mom, he's sitting there. They sit down, watching TV, and all of a sudden she starts screaming, there they are. There they are. Look, out the window. There they are. What is she seeing?
Reflection.
The reflection. The reflection of them in the window, the reflection of the TV. But because the son actually decided, okay, we're going to find out what's going on here, and went and sat with her and put himself in her shoes to assess the situation, all he had to do was close the blinds down. And the person's gone.
Why did you wait so long to do that? Sounds like that she did it for quite some time.
Do you know how many family members take an active role as a caregiver? No. My nephew would go see his mother maybe once a year. After telling me, put her in nursing home. Okay? Even when she was dying, in her deathbed, ready to go, he'll disappear.
I think one of the just really important things, and we kind of brushed over about boredom. Boredom is such a trigger. It increases. If we don't have anything that you're able to do that makes you feel good, that you feel productive, that you're feeling that you're giving back, that you feel that you're doing something that you feel good about yourself, it's going to make you feel bad. We all know that feeling. You know, if I don't get to go to my exercise class a couple of days a week, I feel grumpy. If I don't have something to do on the weekends, I'm searching to find something to do. But the difference is I know how to reach out. I know how to call my girlfriend, or I know how to talk to my husband and say, hey, what do you want to do tonight? What do you want to do this afternoon? But a person with this disease, they don't have that capability. So we need to help them to have those moments, to have that time where they feel good. I have a trainer that works with me, and she calls it the Peacock Woman. So just imagine the peacock kind of walking around, and then he fluffs his beautiful feathers, and he's strutting around. He feels good. Peacock, that's how we want to make our loved ones feel. That they feel good. So boredom is such an important thing to try and not occur.
Question?
Yes?
So that means that even with dementia, these
still need purpose in your life. as long
Absolutely,
as-
we all need purpose, I don't care what the disease is, I don't care what we all need purpose in our life, absolutely. Whether it means, being able to spend some time with my grandchild on my knee, or being able to, just spend time, playing with yarn or working with yarn, because I was a seamstress, and, working with yarn is something that's safe. But we all need purpose in our lives, and we need to help our loved ones still have that kind of purpose. Thank you, that was a wonderful way of putting it.
I went to a nursing home one day to see my mother in Maine. And they had a elderly woman there, totally out of control. Argumentative, combative, totally. And then nurse goes out, gets a bag of laundry, towels. They're all just thrown in this basket. And goes over to the table and starts folding them. And then talks to the elderly woman and says, I need help folding these, would you help me with that? That was it. Happy, content, and went along and folded her towels. Gave her life some meaning, she was doing something, she was helping someone. The only way we got my sister into a nursing home is because she always wanted to be, into a senior center, was because she wanted to be a CNA. So part of setting up a program, and I'm involved in all this with her, I asked them to set up a program where she thought she was going in there as a CNA volunteer. They let her put her handbag with theirs, they let her put her coat with theirs, they let her help pick up the silverware or set the tables, and she fell into it lock, stock, and barrel, and I never had a problem. Because she now had a sense of purpose. Behaviors, external triggers. Lighting, too bright or too dark. My sister always wore sunglasses. She had to wear sunglasses. It could be dark in the living room, she'd have to have her sunglasses on.
Smells can also be an external trigger. Be really aware of that. Perfumes. Smell of the heating exhaust. Even cooking smells. Sounds. External. Can be a trigger for someone. Smell of smoke. Can be a trigger. Small vibrations. My mother could sense when a car would actually go up the road and it would shake the house. And that would bother my mother. She'd stop pacing.
Decor. What happens if you put a black scatter rug in front of a bathroom door or in front of a toilet? Huh?
It looks like a hole.
Looks like a hole. They won't go over it. And then they gotta go to the bathroom, and then the cycle starts all over again. Contrast. A lot of nursing homes and daycares now are taking their fire doors and making them look like a hutch or a piece of furniture with paint. So when the person with Alzheimer's looks at it, they won't try and open it.
Those are definitely things that you can do in your own home as well. If you're trying to, not allowing, if your loved one is, kind of leaving in the middle of the night, you can actually distract your front door and make it disappear. Paint it the same color as the wall. Get rid of all of the things around the door that remind them that that's the front door, that's the door you're supposed to leave. Distract it, make it look different. I've had families who say, you know what? As soon as my loved one goes to bed, we put, a couch in front of it, we put a chair in it, so the doors disappear. Need to change the environment so that it's, so it's away. We've had people just put construction tape across the door, or that do not
Yes,
What happens if the person has a distorted perception of what is real? Like she keeps wanting to go up to the second floor and there is no second floor. And you try to change the subject, but it doesn't really pay to argue with her because you can't take her up to the second floor. So what happens when the perception is in her mind?
if you have a bedroom with a closed door, say, come on, and open the door and make like you're going up.
I was thinking of a patient that I worked with in a nursing home, and she wanted to go upstairs and pray with her sister.
Yeah.
There was no way we could produce a sister, so I tried to change the subject, but it's tricky.
You know, all of this, it's not easy.
Yeah.
You know, it's trial and error. Things that may work today may not work in 2 hours. So we need to constantly be thinking, well, what could be occurring, trying different, you know, avenues to support that person so that those behaviors that are affecting them can be, you know, we can help or support them in that way.
Redirect. Ice cream. Ice cream, the magic drug. Ice cream. Yes.
We're hearing about this new, possibly effective drug being, at first it was discontinued because it didn't work. Now they find out over a long period of time, it may start working. If you've been in the business, you know what I'm talking about.
Yeah, you're talking about the medication from Biogen. Yeah, absolutely. You know, our stance on it is that, you know, we suspect that they stopped the drug trial too soon, absolutely, but I mean, yeah, absolutely. You know, I know many people who were actually in this trial here in Rhode Island, and whether they were actually on the medication or not, or they received the placebo, some people really seem to be doing really, really well.
The physician in charge of the local,
Dr. Stephen Salloway. Yep.
He was disappointed, really.
Yes, he was very, yes.
And then now it's in around, that's great.
Yeah, I mean, we're excited. I mean, we haven't had a trial medication to go to this next stage of, you know, FDA approval in the last 15 years. So we're hopeful, we're excited about the opportunity, because this is that first medication that we're actually, you know, trying to treat individuals, and we're seeing some change in the reversal of that amyloid tract.
Well, I think it's important to know that in light of everything that this drug is, you could say it's discouraging, but it is. It's reality.
Yeah. Huh? All right, I'm gonna really screw it up. I really am bad. I'm gonna, Adam.
Excuse me, there are people are talking that interferes with the speaker.
It was Abdullah.
I'll look it up and I'll tell you before.
Yeah, it's AD sign.
So, external triggers, activities. Adult. Is, you know, when you're in school and you hate when the teachers are gonna call you up because you did something wrong. Wait till you get your first phone call from the nursing home that your sister's in bed with somebody else. Okay? But you know, they're still looking for comfort and they're still looking for warmth. And it's tough for wives when they hear that about the husbands. But again, it's not them. It's the disease. Possessive of territory. Oh man, I stole everything. I stole her money, I stole her handbag. Anything that was wrong was my fault. Was it worth me arguing about? No. Don't argue with them about anything unless it's got to do with safety. That's all. I'm sure you've probably already been told, it's okay to tell an Alzheimer patient a white lie. There's nothing wrong with it. They come up to you, where's Dad? You know Dad died 10 years ago. So where's Dad? He's dead. What do you mean he's dead? And they go through that. And then 5 minutes later they ask again, you say he's dead. They're gonna go through all that depression again. Dad used to work nights, he has to work tonight. That's it. Done. They ask again, Dad had to work.
That's easier said than done, I think.
Pick something else. Something else they used to like to do. You know? Goal to changing behaviors. The goal is to create a positive emotion in the person with Alzheimer's. So she started folding the laundry, it gave her something to do, some purpose in life. She was happy. My sister was going in as a CNA. She was happy. Maintain the positive emotion over the course of the day. Caregiver must ask, how is what I am doing right now creating or maintaining a positive emotion with the person with Alzheimer's? By giving them a sense of purpose, they're going to calm down. It might not last very long. Then try the ice cream. Problem behavior will be defined differently by different people. And like I said, no two dementia patients are the same. Each of us experience different things in different ways. One is a horrible problem that, for one, may be of little consequence to someone else. Something that's big and might be bothering you might be nothing to somebody else. Husbands know it with the wives. Could have to do with past history and unresolved issues. One of the things when I used to go visit my mother, after they put her in the hospital when they worked on her ankle, all I heard about was how they used to take her out at nighttime, take her downstairs and operate on her, and the Nazis would take out all of her organs. Okay? With my mother-in-law, we were talking about the cotton and stuff. My mother-in-law's family had a plantation in Brazil, and they had slaves. So we would hear about that as time went on. You know, it's just, you know, I can't get into that, I'll say something wrong. Manage behaviors for providing an Alzheimer's friendly physical environment. You know, what color is a gallon of milk? White? What color is a gallon of bleach? White. Do you think they can tell the difference? No, they can't. They cannot do it. If you take your house and you baby-proof it, you should be doing the same thing for an Alzheimer patient. Same cupboards, the same everything. Because they will go in, they will go through the cupboards, and will unknowingly do something. Stoves, microwaves, toaster ovens. Why would you want to leave them plugged in?
So I heard a great, and I never thought of this, but do you know the little, there's plugs that we use for children to put in the outlets? This is another one that I thought was great. There's those little plugs that when you first get your toaster oven, they have those little clear caps on the top. I never thought of that. Someone told me that yesterday, and I was like, what a great idea. But when you talk about, safety proofing, we're talking about, because we want our loved ones to be able to stay in their homes safely. And so we have to adapt the home so that they can continue to thrive, that they continue to enjoy the place that they have been living for so many years, because it's familiar to them, it feels comfortable, it feels safe. So we want to be able to think about how can we adapt so we can hopefully keep that our loved ones in their home for through the journey of disease. We want to make that an enjoyable happy environment for them to live in.
Good communication skills. So I'm 6'4", at X amount of pounds. And I used to manage thousands of people, and I was always known as a gruff person. You wouldn't believe that, would you? So if I went up to you and said, "What do you want to eat tonight?" Okay, that's not good communication. Sorry about that. Usually I use my wife, she's up here. That's not good communication. Because they're gonna do the same thing. They're gonna put their head down, they're gonna yell, and they're not gonna get anywhere.
Or they may smack you. Or they may push you away.
Yep. You know, get down to their eye level so they can see you.
One thing that happens with the progression of this disease is their perception changes. Their ability to see things changes. So it's really important, you need to understand that when we're coming into the view of somebody, they're processing who we are much slower. So we need to really, come to that person in a very, very slow manner. We do not usually want to, talk to someone on the side because they lose their peripheral vision. And then, when you think about it, for many of us who are aging, we already are having, visual changes. I have visual, perceptual things that I have problems with. So I make sure that when I'm talking to people that I'm actually looking at you because I can't see you from this side. So you want to make sure that you're facing that person in front of them so that they can see you. So they can see your face. You're talking to someone from the side. And it's also really scary when you're approaching someone from the back. I know if someone approaches me in the back, I jump. They touch me on my back, I jump. Can you imagine what it might be for someone with this disease? So we want to make sure that we approach them from the back. And we need to know if they like touch. Because touch could be very upsetting for somebody. We need to know the person that we're providing that care.
When it comes to touch, we go visit my sister in a nursing home, and I could sit there probably for a half an hour, and just rub her arm. And maybe at some point, I would hear a coo or a movement. And then my day was made, because then I would know that she knew I was there and she appreciated it. Before you go that far, you're into the middle stage, beginning and late stage, they'd love to have their hair brushed. They'd love to be touched. Just like we do. It's always nice, scratch my back or something. It's great. If I go up to my mother now and start scratching her back or rubbing her head, she's not gonna let me leave. All right? But they need this love. They need this closeness. Appropriate approaches to offering assistance with personal care activities. As her brother, there was a couple times where I had to get her undressed and get her in the shower. Did I like that? Absolutely not. And it wasn't too much longer after that we ended up getting a CNA.
With that, I think it's really important that we really know what our routines are. I can tell you from the time I was a little tyke that I got up in the morning, first thing I do is I wear a bathrobe. As soon as I get out of bed, I wear a bathrobe. I wear pajamas to bed all year round. Doesn't matter, I wear flannel pajamas. My mother wore a nightgown. Every morning, I have the same routine. I get up, I go and have my coffee. I like my silence in the morning. I don't like anybody bothering me. I get in the shower. I have a certain routine that I take. We need to pay attention to what are those routines that our loved ones have. Because part of our role in caring for them is we're going to have to try and stimulate and continue those routines going for them, if at all possible. Because they'll be able to, it's like, that feeling of, you know, it's comfort, it's 5 o'clock and you hear the bells, you know, the alarms going off, and you know, my dad's coming home, or my husband's calling over the time. We remember those things, and so we need to know what our loved ones' routines are, so that we can support them in those kind of personal needs. But that's really, really important.
All right, and these provide opportunities to develop positive emotions in the person with Alzheimer's disease. ABCs. A, antecedent, identify what happens just before the behavior occurs. Again, stop, assess what's going on. See everything, put yourself in their shoes. Why are they acting like this? Is it 5 o'clock? Is the dog barking? The stereo up loud? Behavior, identify what type of behavior occurs. It wasn't hard for me to figure out one day when I got a phone call from the daycare that my sister had cornered the director in a closet. All right? Then I knew it was time for a neuropsychiatrist and getting into psychedelic drugs. But again, you gotta assess the situation, see what's going on, and then react. You ask them a question. Ask them a one-answer question. And then count to 5. Don't expect an answer right away, because you're not gonna get it right away. It's gonna take them that much time to try and understand what you're asking or what you're saying. You might have to repeat it again. And on the other hand, don't ask them a question. What do you want for supper tonight? We're gonna have a bologna sandwich, or a turkey sandwich, or a peanut butter and jelly sandwich, or a hamburger. What do you want?
Ice cream. I play the game.
That's it. Good for you. That makes up for the scare. But no, we're gonna have peanut butter and jelly sandwich tonight. Don't ask them to make up their mind, because they can't. And then you're gonna get frustrated, they're gonna get frustrated, and before you know it, it's gonna be out of control. This is supposed to be a caring, loving experience. C, consequence. Identify the outcome of the behavior. Ice cream, that'll work. We have somebody who puts out buttons, a jar of buttons, and asks their loved one to sort it. Go to a nursing home. Woman is totally out of control, tearing up a magazine, just out of control. The nurse comes over and says, if you don't stop this, I'm going to lock you in your room. Do you think that helped the situation? Absolutely not. It made it worse. Nurse walks off. CNA comes over, says the same thing. If you don't calm down, I'm going to lock you in your room. Woman's totally out of it. Go on. She's just, nothing's going to calm her down. And then finally somebody came over who was visiting somebody and said, I'm going to color in this coloring book. How would you like to color with me? That was it. Happy as a clam. Took the crayon, one crayon, and started coloring the whole page. Happy. Somebody finally knew what was going on. And I can tell you that these people didn't know who I was or what I did. But all it took was one sit down with the director, and both of those people were gone. Never to be seen again. It's wrong. If you cannot be a caretaker, don't do it. Don't do it. 63% of caregivers die before the loved one. okay? Why? Because they can't handle the stress. So if you can't handle it, and you're gonna kill yourself, don't try doing it.
So what's the answer then?
What's that?
What is the answer if we'll say, like you and your wife, that have been so hands-on with your family, if you couldn't do that, what is the answer then?
In our case, all right, we end up, we went 2.5 years before we ever went out alone. Every place we would go, we'd have to take her. And finally, one day I said, that's it. I can't do this anymore. I wanna go out with you, and I wanna go to a restaurant, or to a movie, or shopping. Can't do this 24/7. So at that time, I talked to our parish priest. I do a lot for the church. And he had a niece at that time who was 15, who he said was very mature. So we invited her over. 3 times we sat there with my sister and had coffee and we had a good time. And it was really nice because at this time, that's about the age level that my sister was at. Mentally. You know, your age levels go down as the disease progresses. She would spend hours in a mirror talking to herself. Hours. You know why? Because that was an old lady in the mirror. She was thinking of herself at 15, 16 years old. She had no idea that that was her. But she was happy and laughing, and that was fine. So this girl that we got, they were at the same age level, worked out fantastic. Excuse me. We had her come over every week until we moved her to a nursing home. And they would sit there and she would paint her nails, brush her hair, and do everything that kids do. She'd bring over these, you know, funny videos. And they'd sit there and laugh, and they would have a great time. So my sister would feel fulfilled and had a purpose. And when it came down to it, towards the end of it, she thought that she was taking care of the girl.
Yes.
Fine. Right? We assessed it, we got it taken care of. From there we had her, then we ended up getting a CNA approved through Medicare, Medicaid. It was 10 hours a week, so that helped us, that helped me. So I didn't have to worry about changing her and cleaning her and all this stuff. And that went right on until we got her into a nursing home.
You know, again, that's what we're talking about, is taking care of yourself. You know, there's a lot of creativity that families have to do. I've seen families having to kind of piece together, you know, their care and the support that they're giving their loved ones, you know, inviting, you know, family members and friends to come in and, you know, come in and spend time with that person so that you, as a caregiver from the church, can go off and do something so that you can take care of yourself. It's so crucial. I can't tell you. I mean, caring for my parents, I developed high blood pressure in my late 20s because of the stress I was experiencing. And unfortunately that pressure issue is no longer, but it was temporary, and I had to figure out, what I needed, so I could care for, so I could actually be there for my mom and dad. It's so important, and just getting involved in, support groups, or having other people that you can, talk with about what you're going through, and getting ideas from each other can be so helpful, so that you're not feeling so isolated in your role in taking care of your loved ones.
You gotta take care of number one, and that's you. Because if anything happens to you, what happens to them?
The way you're talking, it sounds like it's a 200% job, 500% job. Where do you take the time to get involved in support groups? I mean, where's the time?
Yep. Respite care. Okay. We talked about this already, approach from the front, calm, take your time, count. Pay attention to the person's nonverbal. Are they walking around bent over?
So
Eye contact?
So I'm gonna say to you, I know the rest of this presentation, and there's a lot of sort of repeat, because there's a lot of repeat and reinforcement of the things that we've already gone over. I wanna just be aware of time. It is just a little bit after 7:30, and I wanna give people opportunities to, ask some questions, and I apologize, but I was looking at the time. But we talked very specifically about some approaches in the communication. But does anybody, I think I did hear a few grumbles of, this seems so daunting and so sad. But I truly, feel that, there's a lot of love and a lot of good times that we can have with our folks that we're caring for. And we need to make those moments and those memories so good for yourself and for the person that you're caring for. It can be a wonderful, it can be difficult, but it can be a good experience for you because of your approach and the support that each one of you are getting as a caregiver, and the time that you take to really provide that loving support for the person that you're caring for. There can be a lot of laughter. We need to be able to find the humor sometimes in the things that we see, and